The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
A monthly webinar series from the Limi Hospitals. Today, Limi Children's Hospital will be broadcasting live and we are set. We'll move in straight. So these are hospitals composed of three standard interconnected hospitals. The Limi Multi-Specialty Hospital, which is our headquarters in Central Business District with all the activities, various departments as outlined on the screen. Then the Cardio Care Multi-Specialty Hospital, which is for cardiology services, cardiac intervention, catheterization, and with all the major subspecialties in internal medicine. We are from the Limi Children's Hospital, and we will be handling today's webinar series. This is who we are. Our services include pediatric cardiology services, and the pediatric cardiology team will be presenting today. We'll have other teams presenting subsequently on a monthly basis. We have other services as displayed, and this is our neonatal intensive care unit. This is neonatal echocardiography that is going on in a transport incubator by one of our pediatric cardiologists. Yeah, so we are up to the main item for today. So what do we have for today for our listeners?
So my name is Dr. Ejime Omokwali. I'm a pediatric officer at Limi Children's Hospital. So sir, we're discussing cardiovascular investigations in pediatrics today. Want to know about the indications and how to recognize some patterns.
Okay, yeah. So I'm Dr. Peter, pediatrician. So this is our outline.
So what do we plan to gain today as our listeners? So we want to go through a brief introduction, want to know some common indications, want to go through some shared medical patterns of common cardiovascular abnormalities that can be seen in children. Then we'll go through some brief ECG tracings and patterns, and have a few slides on echocardiography also. And to also know about some other investigative modalities that can be used.
Yeah, so in essence, by the end of these presentations, our listeners should be able to know when to investigate children and identify, and should be able to interpret some basic findings. Yeah.
So now, why do we need to investigate? We need to investigate, so as doctors of all cadres, we need to be able to investigate common abnormalities, so be able to take important decisions as regards early management or appropriate referral. So all doctors need to be able to know and to spot various common cardiovascular abnormalities in all ages and groups of children, especially.
Yeah, so because of the contribution of cardiovascular pathology to under 5 mortality, which is unacceptably high, we in Limi Children's Hospital want to contribute to attainment of the Sustainable Development Goals, where we reduce under 5 mortality substantially. Now, if doctors listening to us are able to know when to investigate, and then the investigations that are common to them, they can make some sense out of it, then those they can treat, fine. Those they cannot, they refer early to centers that have pediatric cardiology services. Yeah, so we are talking about investigations, indications, and the patterns. But before we jump into investigations, it's important that we know that history taking and physical examination remain the bedrock, because a good history physical examination gives us the pointer. The fact is this: some congenital or even acquired cardiac conditions may not have clear-cut chest X-ray findings, especially those mild ones that are yet to become complicated. Picking them early, you may not show. We'll see some as we go ahead. We'll see why we said so. So history is important. So now, a mother brings the baby to clinic to see, maybe for consultation. What are those stories we hear from the mother, and what are those things we will get to pick from the parents? That's what we are discussing now. So like fast breathing at rest or while sucking. So you see, for us as adults, if you want to know the cardiovascular integrity of an adult, say let's jog from here to from Abuja to Niger State marathon race, then you easily pick up those who need to urgently come to cardio care for investigations, right? So, but for babies, exertion is when they suck. So a lot of energy is put into sucking, you see. So babies who get easily fatigued while sucking, or even older children that get really tired with normal level of stress, they need to be investigated. We put the sentence pale gray coloration of the mucous membranes because mothers won't tell you cyanosis. So there is a discoloration, dark discoloration of maybe the lips, the tongues, the mucosal surfaces. That's cyanosis, but they will report it as gray. This needs to be investigated. We know that when we say a baby is failing to thrive, it could be because of nutritional or because of some organic problems. So an existing cardiac pathology in a child will affect growth. So the child is not growing well. We shouldn't just say go and take multivitamin, go and eat balanced diet. It's not always. Investigate that child more closely. When we have recurrent chest infections, there's either a problem with the pump, and it is cardiovascular. There's either a problem with the pump function of the heart, or maybe there's a shunt lesion. So when there's increased pulmonary blood flow, we find that there's so much flooding of the lungs, they come down with frequent chest infections. Now, frequent squatting, which, if not closely looked at by the uninformed, may just be is a habit, is a pointer to a clear-cut congenital heart disease, which we call tetralogy of Fallot. But tetralogy of Fallot, will discuss more about the investigation patterns as we go on. Now, these are the things, common things mothers will say. Now, as a doctor, what will you find when you see?
So it can be systemic. We can start from the head to the toe. So now they may complain of the pale gray coloration as seen in this sign. So they may have pale gray or darkish, maybe the mucosal surface, or even in the fingernails or the extremities. So the toes or the fingers. Then they may have this bulbous appearance of the nails, both in the fingers and in the toenails. So they may have this digital clubbing appearance too. Then now, dysmorphic fasciitis. So the child may have different features such as maybe low set ears, hypertelorism, or even have a small jaw. So now this may be a prompt towards a possible heart defect in children that have this kind of abnormal appearances. Now, you may have a decreased amplitude of arterial pulses. This basically just says that there'll be a low pulse volume. When this happens, our mind should go towards a possible obstructive lesion, most likely systemic in most of these children. Then the last one, murmurs. So a murmur is an abnormal sound heard when there's turbulent flow through the chambers of the heart or a blood vessels or a normal or abnormal valve. So there are different kinds of murmurs. They vary in intensity, in size. So now we need to be able to train our ears, be able to know and to be able to identify certain murmurs that could need urgent medical attention.
Yeah, so we'll quickly go to cyanosis. So let's have some discussion on cyanosis, because we know that our listeners will be saying, what about peripheral cyanosis? Come on, do you investigate children with peripheral cyanosis as those having congenital or acquired heart disease? Well, we are talking about central cyanosis in this situation, because peripheral cyanosis is just a response to the ambient temperature environmental, which is really not from a systemic pathology. But in cyanosis, there is desaturation. So the oxygen saturation is also low. So oxyhemoglobin, which is deoxygenated, will manifest where it should. Now, we want to introduce the concept of differential cyanosis and reverse the differential cyanosis. And we want our listeners to pay particular attention and be able to identify this. Yes, the discussion today is on investigations, but we want to let you know that a lot of diagnosis can be made just from examination. You see, so the presentation, we know we are targeting a lot of audience, maybe practicing in tertiary centers or even primary healthcare centers. You could actually, it's our desire that we want to make sure that children with heart conditions are picked early and given the best. Now, in central cyanosis, if we have a situation whereby the lower limbs are cyanosed, but the upper limbs are spared, it's called differential cyanosis. So this should be very clear. So now, if it's peripheral cyanosis, we shouldn't have the central spaces, mucous membrane cyanosed, just extremities. But now we have mucous membrane cyanosed, we have lower limb cyanosed, but we have the upper limb spared. It's differential cyanosis. Now, it's found in conditions like patent ductus arteriosus with pulmonary arterial hypertension. That's why this diagram is here. If you can see my yellow cursor on the screen, let's look at the diagram of this aorta. So from the aortic valve, we have the branches of the coronary arteries, then ascending aorta, then with a branch on the left, we have the brachiocephalic trunk. Sorry, that's the right, brachiocephalic trunk. And then the left side, you now have the other arteries. So the arc of the aorta and then descending aorta. It's simple for me to accept that everybody understands what I have just said. Now, we know that in the anatomy of the vasculature outside the heart, there is the pulmonary trunk that sits in this space between the ascending aorta and the descending aorta. Now, the ductus arteriosus is a channel that connects the upper border of the branching of the pulmonary trunk to the lower border of the arc of the aorta. Now, if we look at this very well in our bid to explain differential cyanosis, if there is differential cyanosis, a PDA is actually left to right shunt. So left systemic to pulmonary. But if the PDA has remained so long and is causing pulmonary vascular changes and there is pulmonary arterial hypertension, the pressure on the right chambers increase. So pulmonary arterial pressure will now cause a right to left shunt. So the shunt from that pulmonary is entering the ductus arteriosus, and then it's coming. So the blood that should have been oxygenated in the lungs is not oxygenated and is shunted down the descending aorta. So oxygenated blood that comes out of the aorta and climbs towards the ascending aorta, the vessels, upper limbs are spared because they would have received their supply before the place where the ductus arteriosus joins. So distal to that, deoxygenated blood flows. So we find the descending aorta that goes down to supply the lower limbs, supplying deoxygenated blood, while oxygenated blood is supplied to the upper limbs. So we have differential cyanosis with cyanosis of the lower limbs and sparing of the upper limbs. In patent ductus arteriosus complicated with pulmonary arterial hypertension, even in neonates with persistent pulmonary hypertension of the newborn. Now, the physiology is the same because in persistent pulmonary hypertension, the pressure is so high and is sustained by shunts. So the shunt could be a PDA, it could be an ASD. So hypoplastic left arc syndrome. Yeah, so the hypoplastic aortic arc. Yeah, so the same, and then critical aortic stenosis. So these are conditions where you can have differential cyanosis. Now, reverse this differential cyanosis. In this case, there's cyanosis centrally, upper limb and lower limb. But the upper limb is more cyanosed than lower limbs. Nothing will replace good clinical examination in medicine. Not even technology, maybe. So in the transposition of great vessels, because the vessels have been transposed, the vessels, there's vascular transposition. So saturated blood from the pulmonary circulation supplies the aorta via a PDA. So everything is mixed up. Normally, the aorta should come from the left ventricle and pulmonary trunk from the right ventricle, but there's a reverse, and then the connection is via a PDA. In this condition, we have reverse differential cyanosis. If we have that, even without doing a chest X-ray and even without doing echo, we can suggest very well, very likely, the transposition of great vessels. Yeah. So now, my co-presenter talked about murmurs as abnormal sounds that are heard in the cardiovascular system as a result of the vibration set up from turbulence flowing across diseased apertures like valves, like unusual shunts, or even from vessels. So the auscultatory areas are 4. The apex, the lower left sternal edge, the upper left sternal edge, and the upper right sternal edge. So depending on where we are auscultating and the type of murmur, we could talk a lot about what possibly could be this congenital heart disease. It's good that we separate innocent murmurs from pathologic murmurs, but leave that for pediatric cardiologists. If we hear innocent murmurs, we know. But generally, let murmurs be investigated. But pathologic murmurs could be diastolic or systolic or continuous. So it's a diastolic murmur if the murmur is heard in between the first and the second heart sound. The unusual sound is heard between the first and second. It's diastolic if it's heard after the second heart sound, and it's continuous if it's heard around the phases of the cardiac cycle. So if we pick a murmur at the lower left sternal edge, we are thinking of a ventricular septal defect, even what occurs in endocardial Cushing defect. So that's a tricuspid area. Tetralogy of Fallot, because of the VSD, although the main component in TOF is a pulmonary, so the right ventricular flow tract obstruction. So these are various sites of various murmurs and their associated pathologies. We'll go quickly to the investigations. But we'll talk a little about NEDAS criteria. It's important that we see the signs that make us suspect a heart defect. And for screening, because you cannot have all babies born in a center screened using echocardiography. So what do? You cannot have all babies that come to clinic investigated. So what do? These are the criteria we use. So you tell us about NEDAS criteria.
Okay. So first of all, we need to know that we need to have a presence of 1 major or 2 minor criteria to suggest any congenital heart disease. Now, the major ones include a systolic murmur more than a grade 3 murmur, a diastolic murmur, the child may have cyanosis, and there may also be presence of congestive cardiac failure. But the minor criteria include a systolic murmur less than a grade 3, so you can have a grade 1 or a grade 2. An abnormal second heart sound may also be heard on auscultation. Then the ECG will not be normal for that age of the child. Then we may have an abnormal chest X-ray seen. Then the blood pressure will be abnormal for the age. So when we have 1 major criteria, or even 2 minor, it's not for us to probe further, do an echo, and do other investigative modalities for the child.
Yeah, so it's really, really important that clinicians bear this in mind so that we don't reassure children without a basis. That's one of the greatest errors that doctors should never make, reassurance. Okay, fine. Yeah, so we get into chest radiographs. It should get interesting at this point. Wow. Okay, fine. So what are abnormal chest radiograph patterns?
So I think we're all familiar with chest radiograph. So there are different ways to read one. You can start from the outside to the inside, or from in to out, but I won't go into that in this presentation. So now let me start with the first one. So now, what is the cardiac silhouette? So looking at the X-ray, chest X-ray, is just the outline of the heart and the great vessels that you can see. So now, if you see a boot-shaped heart, so now normally the cardiac apex showing on this A now. I hope you can all see my cursor. Yes, now. This is the cardiac apex. In the normal heart, we expect it to be pointing downwards. When a boot-shaped heart, it is pointed upwards. That's the apex now as a boot. So this can be seen in tetralogy of Fallot. But remember, the pink variant of tetralogy of Fallot does not have this appearance on the X-ray. And also, because atresia can also present with a boot-shaped heart, just to note and to differentiate.
Yeah. So as during undergraduate days, this question could just come. Tetralogy, boot-shaped heart is pathognomonic of tetralogy of Fallot, true or false? Of course, the answer will be false.
False. Because you can also have it in tricuspid atresia. Now, this second diagram looks like an egg. As if the egg is lying on its side, or an egg with a string just holding it out. So now this can be seen in interpretation of the great arteries. There's also increased pulmonary vascularity. Why? Because the left ventricle, and rather the aorta arises from the right ventricle, which usually go to the lungs. So the lungs is then flooded with a lot of blood. You can see a lot of pulmonary vascular markings on the X-ray film. Now this figure of 8, I don't know if we've all seen a snowman before. They have like a rounded upper body and a rounded lower body. So now this looks like a snowman, this circular part. So it's seen in total anomalous pulmonary venous return. This basically means that the pulmonary veins don't enter into the left atrium. Instead, they enter into the right atrium or through another connection seen. Now, figure of 3 is in the condition of aorta. The diagram will be shown in later slides.
So we'll see more of X-ray films.
Now, the next thing is the cardiac size. We need to know a normal cardiac size, know an abnormal one, first of all. So we need to be able to check X-rays more, like to be able to know how a normal X-ray should look like. Now, if it's a large size, you could think of maybe a shunt lesion, such as a ventricular septal defect, a heart failure, or even a pericardial effusion. Remember, this is not seen in TOF.
Yeah, so once we see a large cardiac size, I am almost certain this child does not have tetralogy of Fallot. Yes.
Then, but if it's an extremely large heart now, our mind should go towards Epstein's anomaly, which can also be called initialization of the right ventricle. So here you have a very, very small right ventricle, but a very, very large right atrium seen. Now, if the aorta, normally the aorta should be positioned in the midline, and it should be towards the left side. But when it's on the right side, we could think of maybe a TOF or a persistent truncus arteriosus. Now, our livers are usually towards the right side. But now, if you are seeing this on the midline, you might should think of possibly a complex and a multifunctional cardiac defect. So you should have to investigate further to be able to know what is causing this complex defect that may be seen.
Okay, fine. So this slide has summarized everything we will be discussing on abnormal chest X-ray. So we'll now dive straight. Okay, fine. Before we even go to the various ones, determination of cardiac size, because we say when cardiac size is abnormal, you are thinking of maybe myocardial dysfunction like a dilated cardiomyopathy or a large shunt lesion or Epstein's anomaly. So can you tell us how to determine cardiac size first of all?
So we can bring a plain chest radiograph. You can use a ruler and a marker. So you want to draw a line through the midline of the X-ray. Then now the widest diameter of the heart to the right side is your A. Widest diameter to the left side is your B. Then you want a line drawn between the widest diameter between the two ribs. As you can see, this is my C. So the formula is now going to be A plus B over C. This should be more than 0.5 in children. Remember, children have a different outline of heart than adults. I remember also in children, they might be able to make good inspiratory efforts. So you have to employ both your PA views and lateral views to be able to have a good estimation of the child's cardiac size.
This is very important because a lot of pediatric chest X-rays will bear in mind the effect of inspiration. So I'll talk about this normal, very normal heart and the sizes. Then my co-presenter will talk about things that are abnormal. I talk about normal things. She talks about abnormal. All right, fine. So this is a normal heart. We see the apex, which is formed largely by the left ventricle, pointing downwards and to the left. The largest part of the base is formed by the right atrium, with contribution from the inferior vena cava. And then the right border is formed by the right atrium. And if we look upwards towards the middle mediastinum, we have the aorta arising and it arcs towards the left. So towards the left, we have the arc of the aorta where it's descending, and then the right ventricular outflow tract. This is important to note because in all the abnormal chest x-rays we shall be reviewing, we'll bear in mind there's an abnormality either in the position and direction of the left ventricle, or a problem with the size of the heart, a problem with the middle mediastinum. Something is wrong somewhere. So go ahead. So now, yeah.
I think we can all remember. I hope we are all following. So now remember, this is a boot-shaped heart. It looks like a boot. You can see this part, the apex is turned upwards. There's also some pulmonary oligema. You can see this part of the film appears a bit darker. Now this should point us towards what? Tetralogy of Fallot. Also, we have a wide superior mediastinum also. So now this is a boot-shaped heart.
Yeah.
Now, okay, now this next slide shows it, as I said before, the egg on its side or the egg on a string. Now, you can also see that the long field appears to be highly vascularized. This would point us towards a transmission of great arteries on this slide.
So this is like emphasizing what we've said in the previous slides and bringing it really home. So this is spot diagnosis. Any doctor working anywhere that sees this kind of heart, this is TGA. You don't reassure this kind of parent. You don't wait. We have faith, but we also add a little work. Let's investigate and know what it is. Yeah. So this is figure of 8. This figure of 8 sign, or the snowman sign. I think it looks like a beautiful figure 8 I've been hearing as part of fashion recently. So this is a figure 8 of our fashion people. Yeah. So you find that the actual cardiac, the heart itself, the heart with the chambers form the lower part of the 8. Now the upper part is the image impression of the vessels that ordinarily should have entered, that's the pulmonary veins, that ordinarily should have entered the left atrium. They form a plexus above the heart because they are branching to enter the right atrium. So they cross the midline and the X-ray is going to pick it like that. So it's either we take it as a figure of 8 or the snowman sign. So snowman sign, figure of 8 should quickly point us to a total anomalous pulmonary venous drainage. So I'll talk about this coarctation of aorta. We see that the cardiac size itself looks good. The position of the left ventricle itself looks good, but the problem is with the superior mediastinum. So we see the aorta will arise, then the arc of the aorta towards the point there should be a descending aorta. There is a narrowing, so the coarcting. So it gets squeezed at that point. That's why it's coarctation of aorta. So this green line shows the figure of 3 that occurs in coarctation of aorta. Now, remember we said in our introductory slides that not all cardiovascular abnormalities would have imaging abnormalities immediately. Coarctation of the aorta is notorious for that, depending on the age. Let me go to the next radiograph, then I'll come back. You see the white arrows pointing towards rib notching. So the neurovascular bundles contain the aorta, the vein, the nerves. So the arteries that pass there supplying the thoracic cage, they are pumping against so high a systemic pressure, and then they erode the lower border of the ribs. So there's rib notching, there's figure of 3. But I bet you get a 2-year-old with coarctation of aorta, you won't find this. Because the older the child gets, the more the pressure builds up, then you see these abnormalities. So that's why we say history is very good, but it's important we're able to identify the abnormalities. So figure of 3, with rib notching, you are talking about coarctation of aorta. Good. Yeah.
So we can see this very, very large appearance of the heart. So now this shows water bottle sign. So you know, in an effusion, there's actually a lot of water and fluid surrounding the heart itself. So we have an increased CT ratio of more than 0.5. Then we have a globular appearance. So the heart casts this globular shadow. Then we have some, I think, some widening of the superior mediastinum too. So this is seen in peripheral effusion. Then also to note on ECG findings.
Okay, so wait, when we say so the globular heart talks about pericardial effusion. It's also called water bottle heart. But please let's note, those who are parents, the water bottle our children use to school these days are plastic, cylindrical. That's not the type of water bottle we are talking about. What we're talking about, this one looks like the one palm wine tappers use. It's old, it is skin, made of skin. So this is a kind of water bottle in case we may have people who may be confusing, expecting to see a cylindrical structure. Yeah, so when you say water bottle, it's skin, so it's old. Yeah, so still on pericardial effusion. Yeah.
Then the ECG, you can see they have very low voltage amplitude on the ECG. You can see the low voltages of the ECG tracing.
So ECG voltages, there's a pressure, external pressure. So the electrical activity is not firing as it should. So the amplitudes are small. We will stop at this for pericardial effusion because pericardial effusion can be in tamponade, and then you start seeing pulsus alternans. But where we are just stopping at pericardial effusion just to emphasize that the voltages are low. Else, the ECG tracing is otherwise normal. So this session of chest radiograph ends with an ECG. So we get to ECG itself. Basic ECG patterns. It's important, although part of the Limi Hospital webinar series, we would have a full session dedicated to pediatric ECGs. But for today, we are looking at just basic patterns. We assume that any doctor at all that stumbles onto some basic ECG patterns should not miss it. This does not necessarily make you an expert in ECGs, which we will try to make everybody subsequently. But today, we're just looking at patterns. But before we go ahead, this image here tells us a lot. So we have let me call it the V leads. So V1 to V6, V7. So those are the precordial leads. Now, this is pediatrics, and we are different from adults. So we have the V4R, V3R, which is an extension of the precordial leads, even to the right chamber, because in early childhood, the heart is right dominant. Yeah, so we have the precordial chest leads. So then we have the limb leads, 1, 2, 3, and then the augmented leads, AVR, AVL, and AVF. So that's just the basic we'll say. And this is the maximum we will talk about basic ECGs, because we'll have another day to trash down ECGs. But just for the purpose of today's presentation, this is a P wave, which is a first positive deflection above the baseline. Then the Q wave, which is a first negative deflection. The R wave is the second and the most prominent positive deflection. Then the negative deflection just after the R wave is the S wave. Then the T wave. U waves, the papillary muscles are firing. So you don't always find it. Now, good. So why we are supposed to know from this what is PR interval. We'll be talking a lot about it. What is QRS interval? What is the distance between two small boxes? It's about 0.4 seconds, which is 40 milliseconds. So let's just bear these three things in mind, then we fire through ECG patterns. One thing, know what PR interval is. Second thing, know what QRS interval is. And then the fourth thing, know the distance between two small boxes. That's all, 40 milliseconds. Then ready, we fire on. Good. So sinus rhythm, what is sinus rhythm?
So now we have a normal sinus rhythm.
Yeah.
So now in every ECG tracing, we have to be aware of 5 things. Number one, they have to have equal RR interval. So you have to actually measure this, maybe be a ruler and a pencil. Then the P wave should be upright in lead 2 and inverted in the AVR lead.
Yeah.
And the third thing, all the P waves, they should all look similar and normal in the shape and in the height and the width. Now, all QRS complexes should be preceded by a P wave, and all P waves succeeded by a QRS complex. I know these two statements sound similar, but they're actually completely different things.
Different. Yeah. So because we could have P waves, and after the P waves, we do not have a QRS complex. It is not sinus rhythm. It is pathology. Or you could have QRS complex, but there is no P wave before it. It is not sinus rhythm, no matter how nice the ECG looks. So this is important. Now, what she has discussed is actually normal sinus rhythm. Means is sinus because the sinoatrial node is located in the right place and is firing well. Right. Yeah, so it's abnormal sinus rhythm is different from abnormal rhythms. Abnormal sinus rhythm, you have everything about P wave normal. That's why it is sinus. But you could have RR intervals unequal. Respiratory changes in pediatrics in children could cause unequal RR intervals. So whereas the sinoatrial node is located in the right atrium and it is firing well, you could have other variants of normal, which is abnormal sinus rhythm. We will look at them as we go. So here we go. So she takes over.
Okay. So we have two ECG traces line side by side. So I want us to all try and look carefully. Now this first one shows normal sinus rhythm. So now remember, we have 5 things to look out for. Number 1, we want to have equal RR intervals. They all seem to be equal. Then the P wave is upright in little. You can see it's upright and inverted in AVR. That's number 2. They want to have all normal looking P waves.
Yes.
I think they all look normal in this diagram, as we can see.
Yeah.
Then we have every P wave succeeded by a QRS complex,
yeah,
as we can see, and every QRS complex preceded by a P wave. That's a normal sinus rhythm seen on this tracing. Now this one, it shows, you can see the RR intervals are not regular. This and this one is not the same distance as this one.
Okay, sorry, let me move. Sorry, our cursor is trying. Okay, fine. Okay. So we see a shorter RR interval here, and we find a longer RR interval here. Otherwise, this rhythm looks almost this is essentially ordinarily these are both sinus rhythm. This is normal sinus, this is sinus arrhythmia. So when we have non-pediatric cardiologists interpret ECGs, or when machines, so ECG machines are programmed to read like adults. So when you use it, it will read this as an arrhythmia sometimes, but really just rest assured, we have normal sinus rhythm here. Yeah, sinus arrhythmia. Good. So it's getting more interesting.
So now this tracing shows sinus tachycardia. So now the normal heart rate varies between the age, depending on the age of the child that you are dealing with, just to note. Now, but in this case, now we have close RR intervals between here and here. You can see that they are much close together.
Yeah.
And also you can see that every QRS complex is preceded by a P wave here. And the P waves, they all do look similar in their morphology. Now this is what we call sinus tachycardia. Remember, they have a sinus rhythm, we have a faster heart rate than normal. Now, this other tracing shows an S rhythm, which is a supraventricular tachycardia. So now you can't really discern any P waves. P waves seem to be swallowed up by the QRS complexes, which are very fast, and the RR intervals, they are very close to each other. So we have a very fast rate in this SVT shown here. Yeah. So here we can't see any P waves. So we have very tall and close together RR intervals.
Yeah, so it's important we note that, just like she said, the heart rate varies with age. As a matter of fact, we could have the RR intervals, in fact, closer than what we have here. Just you find an ECG with crowded RR intervals. If in that crowding you can pick a P wave, then it is sinus tachycardia. The engine is still in the SA node, is still in the right atrium. That's sinus tachycardia. So when you find sinus, maybe a child has fever, the child is agitated, some other things, so you find it. But if you find it so crowded and you cannot pick a P wave, is supraventricular tachycardia. So the P wave is not discernible. It's important that everybody should be. So you see, in very good neonatal units, like our neonatal units where we have some advanced cardiac monitors, we'll have ECG tracings. So anybody, be it a nurse, be it a doctor, stepping into the neonatal intensive care unit and seeing this kind of tracing should be able to say, this is supraventricular tachycardia. So we know what to do immediately. It's very important because children with supraventricular tachycardia, you just leave them, no, they will get into heart failure because the rate of pumping is so fast, there's no time for diastolic feeling. So it's pumping very hard, but it's not relaxing enough. So the diastolic phase of the cardiac cycle is cut so short. So it's just contracting, ejecting blood, and then so you're like busy doing nothing. This is SVT, the heart is busy, but it's doing nothing. So it has to be reversed as fast as possible. And SVT can be converted back to normal with basic therapies. That will be discussed subsequently. Okay, fine. So this slide talks about abnormal rhythms. Abnormal rhythms. Dear listeners, we are going to ask for quiz very soon. We would want you to put your answers in the chat box. We'll give you time and we'll assess our performance. So we are facilitators and want to be sure if we are communicating. So the next few slides will have some quiz for us and let's see how we'll participate together. So in rhythms, you are interested in P wave and QRS complex largely. So we've talked a lot about sinus rhythm. So if P wave is absent, then we know the rhythm is not sinus. Now, if P wave is absent and the QRS complex is narrow and irregular, is atrial fibrillation. We will show the slide of atrial fibrillation. If it is, so it's important because we find our children with valvular problems having a lot of problems. Fine. So if we have narrow, so absent P waves, narrow QRS complex, but it is regular. So irregular means the RR intervals are not equal. Regular means RR intervals are equal. So that's junctional tachycardia. It's important we are able to pick this. Now, ventricular tachycardia should be the easiest, one of the easiest ECG patterns that anybody should bump into and identify because it has zigzag pattern, just jaga jaga like that, like children will say. So there's wide regular QRS complex, but you cannot identify a P wave. So we've talked about atrial fibrillation, junctional tachycardia, ventricular tachycardia. Now, if we have multiple irregular P waves, now P wave related arrhythmias. So we've talked about the ones where P waves are absent and then with differences in the QRS complex. In this case, P wave is present quite well, but they are multiple and they are irregular. We're talking about atrial flutter in this condition. And listeners should be able to differentiate between atrial flutter and atrial fibrillation. We will show them. We said in sinus rhythm, P waves should appear normal. Permit me in all, let me just crack a joke, but it shouldn't be. Permit me to use this word. You know, every child with Down syndrome look like children from the same parent. So P waves should look like children from the same parent. Normal P wave should appear normal all through. But if we have different types of P waves, then we're talking about multifocal atrial tachycardia. It's important to know that. Now, QRS complex related abnormalities, we're looking about AV blocks. So look at it. So let's proceed. Before we go further, in the ECG tracing illustration we put, we say we are very interested in PR interval. For today, we are very interested in QRS duration. And then we just want to know what's the distance between two small boxes. And please, which listener can quickly type, want to know who and who, the fast fingers we have listening to us. The distance between two small boxes equal to how many seconds? we would like to know that and know if we are being followed. So we have, while we wait for the response, we say PR interval vary with age, and you see it increases. Now, this is a beauty of pediatrics. In pediatrics, there is no one size fits all. That's one thing. There's no one size fits all. So also the QRS complex duration, it also increases as we proceed. Now, yeah, so we've gotten an answer. Yeah, so, okay. All right, so we said yeah. So somebody said 40 milliseconds. So we accept this, 40 milliseconds, right? Yeah, so we take the last person, Becky, as most accurate because I am the examiner. I said the distance is in how many seconds. I didn't say milliseconds. So this person got it correctly, but actually the answer is 0.4 seconds. You understand? Fine. So, and that's like 40 milliseconds. So let's say for a 10-year-old child who is, it should be less than 85 milliseconds. So you have
that's almost 3 small.
So just like two and a half thereabout. So this is very important. And whereas with respect to our senior colleagues in adult cardiology, there are some basic, but for us, we need charts. We need these charts to always interpret pediatric ECGs. So we are very accurate. Okay, fine. So we make progress. Yeah, so the main deal has started, atrial fibrillation. Yeah.
Okay, so we can see here, remember, this is a P wave related abnormality. So now there are no discernible P waves seen. Just check out the QRS complexes. Now you can see that there's no positive deflection in front of them. So you have a single QRS complex. Remember, this here is a T wave.
Yeah, T wave.
This is flat.
Yeah.
QRS. So now there are no P waves. And then you have narrow, irregular QRS complex. You can see the length, how the QRS complexes are. They're not up to one box.
Yes.
So they are narrow and they are irregular in shape.
Yeah, so they are irregular in that the peak of the RR intervals are not equal.
They vary.
Yeah, so the peaks are not equal. This atrial fibrillation rate, we could ignore it because in pediatrics, it depends on the age rate. Yeah, so we see the intervals are not equal. If we look at lead 2 is a rhythm strip, so every ECG should have 3 positive deflection above the baseline. The deflection before the largest deflection is the P wave. That's the first positive. So there's none here. Then the most positive, the largest one is the R wave. Then the one after that is the T wave. So we have T waves, but we do not have P waves. The RR intervals, man, they are just so. This is like one small box.
One small box.
This is just one. This is like 40 milliseconds. And then the RR intervals are not equal. So this is atrial fibrillation. Let's see atrial flutter. Okay.
So now you can see the multiple irregular P waves. You can see. Let me use the two.
Yeah.
You can see 1 P wave, 2 P wave. In fact, there are 3 P waves seen between the RR. So you have multiple. So now also, it looks like a sawtooth kind of appearance, as if there's a saw around here. So this is seen in atrial flutter.
Yeah. So it's like the baseline is just is regular. Just a lot of undulations. Now, may I quickly say that if you've looked at a lot of ECGs, don't erroneously judge atrial fibrillation for pediatrics because some children are agitated. They are crying. So the leads on their chest, they're agitated. So there is just that irregular baseline that you find. Not always, but atrial fibrillation is classic, as we have shown. If there's an unsteady baseline, does not equal to atrial fibrillation. But in atrial fibrillation, there is this multiple P waves that look like actually sawtooth. That's one. You cannot pick, say this is the actual P wave. That's so multiple. The QRS complex duration is narrow. The RR intervals are equal. That is atrial flutter. So atrial flutter should always be differentiated from atrial fibrillation, where the RR intervals are not equal. Both of them, P wave is a problem, but then the only thing they have is similar. They have a similar pathologies that the QRS duration is very narrow. Yeah, so that's okay. So junctional tachycardia.
So now we have absent P waves here. You can see that there's no positive reflection before this R wave scene. And now we also have narrow but regular QRS complexes. You can see the R intervals, they all seem equidistant and regular.
Yeah.
So remember, we have narrow QRS complexes and absent P wave scene.
Yeah, so that's for junctional tachycardia. It's important so that ECGs are fine. So this is ventricular tachycardia. It doesn't need any extra explanation. So there is no body listening to us that should miss a ventricular tachycardia. You cannot identify a P wave here. The QRS complex is wide, and then it's just regular, just like a child that you are forcing to learn handwriting. Okay, fine. All right, so this is multifocal atrial tachycardia. In this instance, we have P waves, but the P waves, they are discernible. They are not multiple, but they don't look the same. As simple as that. So every other thing about the ECG may be normal, but never ignore unusual looking P waves. It's important. All right, fine. So good. Our quiz is coming. So we want to just see those who have been following us closely. So AV blocks. So we'll talk about the heart blocks. So please watch out for our quiz. So what about AV blocks?
So now we have 4 degrees. Okay, actually 3 degrees, but you can make 2 into 1.
Yeah.
So now we want to look at for the PR intervals here. So now for the first degree, we're going to have a constant PR interval. We're going to be longer than normal. Remember, this is age dependent.
Yes.
So we have a longer PR interval in first degree, but remember they are constant, but they are longer than normal. Now, second degree type 1, we have lengthening successive PR intervals. So the PR interval, it tends to increase as the tracings go. Then for the second degree block, which is type 2, we have a constant PR interval. We'll have drop beats in between. So we can have a P wave not followed by QRS interval in between 2 different QRS intervals.
Yeah. So we leave out the third degree for now because it's really easy. Everybody can easily identify that. Remember, I said at the beginning of the ECG session that for today's session, we are only interested in PR interval, interested in duration of QRS complex, and what the duration of a small box is. As simple as that. We make the presentation very simple. So if the PR interval is longer, is longer than normal, but is consistently long, then it's first degree heart block. It's simple first degree heart block. If it is longer than normal, and you always find a QRS complex after it, first degree heart block. It's longer than normal, it doesn't lengthen beyond that. But you don't, after some of the PR intervals, you just realize there is no QRS complex. Then it's Mobius type 2, which is second degree heart block. But if you find that PR interval is so milliseconds, the next one is longer than that, subsequent one is longer than that, then you are dealing with Mobius type 1, which is lengthening. Please, this our explanation is important because we are going to identify ECG patterns and know if we are following. Now, the third degree heart block is very simple. There's bradycardia. See, to identify bradycardia in ECG, the RR intervals are far apart. Simple. To identify bradycardia in ECG, RR intervals are far apart. Now, you will realize that PP, interval between one P wave and another P wave, is constant. Between R wave and another R wave is constant, but there is no relationship. So we said for sinus rhythms, this is where you should understand what, sinus rhythm, that there should be a P wave before each QRS complex, and there should be a QRS complex after each P wave. Means there is a relationship, PR interval and QRS complex and P wave, they are related. There is a bond. But this one is to thy tent, O Israel. Okay, fine. So let's look at the first question, please. So who can answer this question? Question 1. Which type of heart block is this? Please, nobody should tell me atrial fibrillation. Let
Atrial
nobody
flutter.
tell me atrial flutter. Which type of heart block is this? We wait for answers, please.
They are prepping up to answer the question.
So let's see. So please type your answers. We wait to hear. So we know if we'll repeat that slide. So nobody else answers. Okay, so what is this? Which ECG is this?
I think let's give them some time.
Okay. Okay, so we will repeat what we said while this ECG is in front of you. So we said that we are looking at PR interval for heart blocks, for AV blocks. So if the PR interval is longer than what is, oh, I get the challenge here. We would help them. I get the challenge. But let me repeat myself. If the PR interval is longer than normal, so that's where the problem is. They don't know the age of this child, and they don't have the normal value for the age. But let's see what somebody. Okay. Oh, please, the chat box is disabled. Okay, so please answer in the Q&A. Please, for now, chat box disabled. Can we enable it? So please put your answers in the Q&A. Thanks. Okay, so while we wait for the answers, okay, we've had some answers. Okay.
Type 1 AV block.
Okay, good. Yes, so
Titilade,
yes.
That's very good.
So fine. So type 1 AV block, first degree. Yeah, first degree. Excellent. Yeah, so we are making progress. That's good. That's great. So why is this first degree heart block? We realize that if we look at lead 2, which is a rhythm strip, just randomly pick anyone, see the beginning of the P wave till the end is larger than, so rule of the thumb, whether adult or pediatrics, PR interval should not be longer than 1 big box. A PR interval that is longer than 1 big box is too long. So we find it here. See from the beginning, it's so long. PR interval is very long, and it remains very long all through. So that is type 1. Yeah, first degree heart block. Fine. So that's very good. So we make progress. Let's see. So what is this? We have purposely modeled up things to know if our listeners are following. So this one, we just want to know. The first person to get this needs an award, a virtual award anyway. We'll give the person a virtual hug. That's a promise. So we see. So let's wait for answers and see. So I'll close this one. So please look at it clearly, closely. Look at the PR interval.
Someone has answered.
Okay, someone has answered, but we will wait. We will wait. Someone has answered, but we will wait for other people to answer.
Yes.
So, okay, another person has said type 1 second degree heart block. I think we should.
That'll be type 2.
Okay. So, okay, fine. This person is mixing up. But I would pass this person because I imagine Moby's type 2. Moby's type 2, yes. Moby's type 2. So let's look at it more closely. So we have PR interval. This PR interval, it's okay. So wherever there, so once you have drop beats, it's Moby's type 2. That's a simple thing. Once you have drop beats. Anyway, should I say that? Because we shouldn't say that.
But you can have it in
because,
type 1.
You know, in type, no. If we look at type 3, because it's not related, some people could misunderstand this at drop. So you see this P wave, there is no QRS complex after it. This P wave has this was so this is a classical case of type, that's Mobis type 2, second degree Mobis type 2. Fine. So here comes the almighty one and the last question for us. So please, who can attempt this? The ECG displayed on the screen. Yeah. So who can tell us this? Okay, so as a matter of fact, dear listeners, this is a hybrid presentation, and we have a live audience in our seminar room, and we have virtual audience. Very this good. Who is this? We need to know this person. We need to know this person. It's both a fast finger and so accurate. So let's wait for other answers. I hope nobody has looked at his answer. So this person is fast, yes, and correct. So we find P waves standing on their own, regular intervals of P wave. We find bradycardia. We said once there is bradycardia. So RR intervals are far apart. So the heart block that has bradycardia is third degree heart block. So see the RR interval so far apart. Let's count the heart rate. Or although today's session is not trained on ECG, but let's count the heart rate. So the number of large boxes between the two are waves. So 1, 2, 3, 4, 5, 6, 7, 8. So 300 divided by 8. This is bradycardia of bradycardias. Okay, thank you. So we'll progress. Fine. So this is why ECG is important, because in a setting where you want to, I am aware that most chemistry analyzers, chemical pathology analyzers, will take some time. But the beauty of ECG is right on the spot, you can say if potassium level is high or not. So from the tracing on the ECG, looking at lead 2, you could easily tell if the potassium is normal, abnormal. In fact, you can guess with accuracy the actual serum level of potassium. So when we have hypo, this is hypo because less than 2.5 milliequivalent per liter is hypokalemia. So it can tell us normal, hypo, or hyperkalemia. Or one of my lecturers say hyperkalemia. So it's hyperkalemia. Now, so there is depressed ST segment. We can see from the S wave to climb up to a T wave, there is a flattening. So when we have depressed ST segment with a diphasic T wave, M-shaped T wave, a prominent U wave, you find that is hypo. That kind of a child needs potassium replacement. So the beauty of ECG, you put the lead, you get the strip, it's not invasive, you get your reading, you correct. Now, when it normalizes, you have your normal reading. So the P wave, the QRS complex, and then the T wave. By the time it's going when you have values above 6, this is hyperkalemia at this point. T waves become unusually tall, specifically in lead 2 and the left precordial lead. Please, I'm making emphasis on lead 2 because it's a reading strip, and the left precordial lead, in cases of left ventricular hypertrophy, you may have some tall T waves. So I do not want us to confuse it. You must have tall T waves in the left precordial leads and lead 2 to say this is hyperkalemia. Now, but when we now have the PR interval prolonging, and then the QRS, so everything becomes too big. When everything becomes too big, that is the so the PR interval becomes too long, the QRS duration becomes too wide, the T waves become too tall. At that point, it's dangerously high. And I mean, by the time you have this sinusoidal waveform, the child is coming home. The child is going home. May we not reach that level. Urgent dialysis is needed. All right, so this is pre-excitation. I hope our listeners are excited with our presentation. We are talking pre-excitation on ECG at the moment. Okay, thank you. So this is pre-excitation. So tell us more about pre-excitation.
Okay, so we can see here we have what you call a delta wave. So I can see how this is the P wave. Usually we have a Q wave here that will drop, but in this case, we have an upward slanting to the R wave. So this is like a delta formed here. So now you also have a short PR interval. I can see because there's no Q wave, we have a shorter PR interval because there's a rise from the P wave to the R wave. Then you may have a prolonged QR resolution because of this upward initial stroke of the delta wave. But there's usually sinus rhythm here that occurs. Now, this is because there may be an accessory pathway that may be firing somewhere in the atrial ventricle that will make us to have an accessory wave. So this can be seen in Wolff-Parkinson-White syndrome too, when it's an accessory pathway too in the heart.
Very good. So if our listeners are excited like pre-excitation as we have, there is another question in the next slide. So look at it very closely. Let's take us through an ECG. So who can tell us maybe let's see the fastest fingers again. These arrows point to what? What do these arrows point to? If you are excited, but we wish you do not have pre-excitation complexes on your ECG, can you type, let's see what we have, into the Q&A, we'll be able to identify it. So while we wait for answers, we know that we said in our previous slide that the we have an answer. Yeah, delta waves. Yeah. Pre-excitation, delta waves. So we are excited. We've gone beyond pre-excitation.
Now we are excited.
The presenters are really excited with the response. So we see that it is sinus rhythm because there is P wave. The P waves all look alike. After every P wave, there is a QRS complex. And before every QRS complex, there's a P wave. The RR intervals are equal. The P wave is inverted in AVR and upright in lead 2. So this is sinus rhythm, but where we have delta wave. For some of them in Wolff-Parkinson-White, there will be tachycardia. So the RR intervals will be crowded together. Yeah, so we are gradually coming to an end of the presentation. So it's important, just a slide on abnormal ECG patterns in congenital heart diseases. So in atrial septal defect, secundum atrial septal defect, there is right axis deviation. I will not talk much about right axis deviation because we promise our dear audience that we will have a session on pediatric ECG simplified. We will make it as simple as anything. So there's right axis deviation, and then there's mild right ventricular hypertrophy or right bundle branch block. For VSD, it depends on the size of the ventricular septal defect. Now, when we have a small VSD, ECG is normal. So you see, if clinicians jump to investigations too quickly, remember at the onset, we're hammering auscultation, examination, history. So if a child has a very small ECG, small VSD, which is VSD less than 4 millimeters, the ECG may be normal. So we still insist on the traditional history, examination, and investigation. But when it's moderately large, then we have left ventricular hypertrophy plus or minus left atrial hypertrophy. So yeah, so yesterday I reviewed an ECG that was reported by a respected adult, due respect to our lovely adult colleagues, reported as left ventricular hypertrophy. And the parents were really, really distressed. But when we looked at the percentile charts, yeah, so the report was left ventricular hypertrophy due to voltage criteria. It looked so professional. But when we checked the age of the child and checked the percentiles, the size of the R wave, the child still fell within the normal limit. So that cleared the doubt. Fine. So PDAs are similar to VSDs in the ECG patterns. So if we have superiorly oriented axis, we have all this. Yeah, fine. Yeah, so we've been talking about 12 leads ECGs, which you just do like a snapshot and go. Now, there is something called ambulatory ECG monitoring. So what about ambulatory ECG? Is it ECG inside ambulance?
No, so now this is when is a 24-hour recording of an ECG reading, or it could even be more than 24 hours. So it's just a continuous monitoring of the child's ECG patterns throughout a day. So the child goes home with a monitor attached to the body.
Oh yes,
And
sorry,
this-
you said
okay.
goes home. This is, sorry, dear
Okay.
listeners, this is Nigeria. These things are expensive. We know the dollar exchange rate. So you give them to go home and they don't come back. So we have ambulatory ECG monitoring in our hospital, in cardio care, LIMI hospitals. So the pattern is the ones I have done, you send them, they admit them. Okay, your child needs ambulatory ECG monitoring. For the period where the ECG monitor will be connected, your child will rest on a comfortable bed. So it's over 24 hours or 24 to 24 hours, but it's continuous. So you may go home if you trust the person. If not, I think it's better we just
monitor the child.
Yeah.
So this can be used to rule out maybe the child may have an abnormal heart rhythm or with chest pain, just to try and check and see if the child may have any abnormal tracings that may occur throughout the day.
Yeah.
Or also, if we want to evaluate, okay, how is our therapy going? Are we winning on these arrhythmias, or are we trying to win on our treatment plan? Can use to monitor progress of treatment and also progress of if child is doing better or not.
Yeah.
Also to screen for arrhythmias in some cases, or maybe say hypertrophic cardiomyopathy, or even after a cardiac surgery for the child.
Yeah.
Then maybe if the child has a pacemaker, or to check if there's any pacemaker failure in the child too.
Yeah, so definitely for children who have bradycardia, okay, third degree heart block, who should have a pacemaker inserted.
Exactly.
You'll be checking, it has to be ambulatory ECG to check the function. Wow, so we are done with ECG. I'm sure we are able to identify some basic life-saving ECG patterns. We briefly go to echocardiography. So this is one of our presenters performing ECG, performing echocardiography. So you could find two preterm neonates inside the incubator with the ECG probe going through the window of the incubator, and echocardiography going on at this moment. Well, I would just say that echocardiography basically we do the 2D, which two-dimensional echocardiography for structure, the M mode for systolic function, then the Doppler to check color flow across valves, across shunts, and then to check pulse wave and continuous wave. We will just go straight to a few we have for us. So this is atrial septal defect. I think the anatomy is so straightforward and clear that anybody should look at it and not be scared to identify an ASD. Okay, fine.
Okay, so you can see that this looks like the heart now. So the heart is lying on the left border.
Yeah.
So now this is the right ventricle. You can see it here, the outline, triangular in shape. We have the left ventricle, which is just very located.
Yeah.
The left atrium, the right atrium. It's like there is a defect between the right atrium. So this septum should be closed normally.
Yeah.
So there's now a small hole, like about 1 cm in length between the right atrium and left atrium. So now this second diagram shows a color Doppler image. So now normally this shows this red and blue. There should not be any mixing ideally. It should just be closed. Now there's some mixing.
If they okay, so raise hand. Okay, please. We are oops. I don't know what happened. Sorry. Okay, fine. Okay. Yeah, fine.
Okay.
So somebody raise hand. We are very happy. You can unmute and ask us. We are prepared to answer. Yeah, 2 participants raise hand. Can you unmute and speak? Or otherwise, you could just type your questions in the Q&A. If you have problem with audio. Okay, so we'll probably just type your questions, we would address them. So this is subcostal view with the defect very obvious where the arrow is pointing. Blood should not flow across that point. So that's what we are having clearly here. Okay, so this is ventricular septal defect. Sorry, I'd like to check if the question. Okay, no question yet. So yeah, so ventricular.
The video went up. So now you can appreciate the right, but this is the apical five-chamber view. So
yeah.
it's different from the other one. So which of the supposal view? Now you can see the right ventricle and left ventricle. So you can see there's a small opening between the right and the left. So usually, I think the membranous type is the most commonest type of the VSD seen. But here it's about 0.8 centimeter, which is 8 mm, which falls into the category of a large VSD. This also shows the color Doppler image of the blood flowing across the shunt scene.
Yeah, with another image, another imaging plane. So whereas the first one is apical 5-chamber. It's apical 5 chambers because we know the heart has 4 chambers, but the aorta has been identified, making the 5-chamber. So it's apical 5-chamber view. So, but this is parasternal long axis view, and we can see the color flow through this patency. That is ventricular septal defect. Okay. Yeah, so this is a patent ductus arteriosus. I will not bother us with the details of the image, but I can simply explain that if you understood the anatomy of the aortic arc and the branches the way we discussed before, and understand that the pulmonary trunk is just below the arc of the aorta and branches under the arc of the aorta, then you understand that this image was twisted upside down to reflect what the echo will show. So that is a patent ductus arteriosus. Wow, so we are getting to the end of our show today. Other imaging modalities, it could be invasive, non-invasive. So the cardiac CT, cardiac MRI, those ones when we want to delineate further. In some complex congenital heart disease, if some vascular pathologies are not clearly delineated, because before the surgeon gets into theater, you want the surgeon to be rest assured you don't run emergencies in theater. You want everything to be very, very well spelled out. So, but now it's known that with good echocardiography, like the one you saw in the previous screen, our machine has very high resolution. You can go as far as possible, but CT and MRI are to augment. Now, catheterization is invasive, so it could be. So this is Limi Hospital cath lab. You see how fine our cath lab is. A very functional cath lab with 24-hour service. Open in Abuja, right? So now, catheterization could be both diagnostic and interventional. So it's not always necessary before cardiac surgeries, but when you want to check hemodynamics, so blood pressure changes. So imagine a child with PDA that now has pulmonary hypertension, early features. You need to catheterize to know the chamber pressures before you see if it is operable or it is inoperable. Wow, so we conclude our long day. Yeah, so
we really need to know how to investigate, how to examine, and what to look out for. So, but the earlier we identify all these pathologies and be able to refer them promptly and to the right authority, the better outcome for the children with these diseases.
Yeah, thank you. So we still have 2 people whose hands are raised. We would be happy if we could hear you, but please, you could just type. We will definitely respond. So we want to contribute to cardiovascular health of children in Nigeria. Those that can reach us would like to help build capacity among the health workforce to identify early, to treat, to refer for expert care as fast as possible. That way, we will contribute jointly to taking care of cardiovascular mortality in West Africa. We end today's session by saying thank you for your participatory listenership. Thank you. Yeah, thank you for the comments we have. We are very grateful for participation. We were happy to see people giving answers. So we have a very good question. Is your cath lab functioning for pediatrics? We are almost there. The cath lab facilities are set, and we are already gathering patients for startup. So once we kickstart, we'll let you know. For now, it's very functional, very busy for adults. but that of pediatrics, we are almost there. Thank you all. So, dear listeners, provided you, because you logged onto the presentation and you, from the email you use, the presentation and your CME points will be sent to that same email. So watch out for our next presentation. It will be about the same time of the month. Next month, we'll have other presentations from our neurology team, from our neonatology team. We, the cardiac team, reassure you that we'll have a session on ECG, pediatric ECG, simplified more than ever before. Thank you all. God bless you. Yeah. Okay, so we're open to questions anyway. So we'll get it. Is your cardiac MRI? Okay. Yeah. So that's on the way. Cardiac MRI, cardiac CT on the way, not fully functional yet. Okay. Thank you. So we end the presentation.
Thank you.
So thank you to our physical audience for keeping awake and understanding what we are saying. Thank you all, and God bless you. Yeah.
The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.